Hi there, I'm the neuromuscular mechanic, and today we're going to be talking about the thoracodorsal nerve block and chemodenervation of the shoulder internal rotators and adductors. A very long title. So the relevant muscles we'll look at today will be the latissimus dorsi, the teres major, and the subscapularis, and other targets will be the thoracodorsal nerve. Now what you'll notice is that there is a key muscle that's being omitted if we're thinking about shoulder internal rotators or adductors. And so my disclaimer is that today we're not focusing on the pectoralis major, and generally that's something we're thinking about when we're trying to target shoulder adductor or internal rotator tone. But today I wanted to show you some sort of slightly more atypical muscles to the general pec major. And again, my videos today show you normal echo texture of myself. So the latissimus dorsi, if we start with that, you take your probe and you put it in short axis along the posterior axillary line about a hand width from the armpit. And the latissimus dorsi will be the most superficial muscle. Deep to it will be the serratus anterior, and that relationship will become important when we talk about identifying the thoracodorsal nerve. So let's get started. So here shortly you're going to see an ultrasound clip. So here we go right now. So here I am, I'm just getting things set up. I've got the ultrasound probe, and now I'm about a hand width away from the armpit posterior axillary line. And the most superficial muscle will be the latissimus dorsi, and then deep to it will be the serratus anterior. Now what you'll notice is that deep to the serratus anterior, you see the hyperechoic bony structures. Those are the ribs, and so we need to be mindful that if we bring our needle in too deeply, there is the risk of getting into the lungs. So that shows that those two muscles. Now I'm going to move the probe around here, but again, hopefully you can identify that overlying latissimus dorsi and then the deep serratus anterior. Now shortly, what I'm going to do is I'm going to now move that probe sort of now more anterior. So here I go, I'm moving it more anterior, and you're seeing the latissimus dorsi is disappearing, and all we're left with is the serratus anterior. So again, if you're too far anterior to the posterior axillary line, like the anterior axillary line or anterior to that, you'll get the serratus anterior. This, for example, will be where I might do needle EMG of the serratus anterior for a long thoracic nerve palsy, but not ideal for finding our latissimus dorsi. So when it comes to the latissimus dorsi and dosing, there's no recommended dose per the product monographs, whether we're looking at Xeomin or Botox or Dysport, so you have to use your discretion. So moving on to the thoracodorsal nerve, as I alluded to, it lies in the fascial plane between the serratus anterior and the latissimus dorsi, and identifying this nerve can be useful if you want to target it for a diagnostic nerve block that can inform you about whether you should or shouldn't do chemodenervation to the latissimus dorsi, or for more long-lasting treatments such as phenylneurolysis, which you could do to this nerve directly. So we're going to start with the same clip as I showed you before. Here I am getting to that posterior axillary line about a hand breadth down from the axilla. And here are the thoracodorsal vessels, and they're very easy to identify, and they lie in that fascial plane where the nerve is. And there's that fascial plane in red with the overlying latissimus dorsi and the underlying serratus anterior. And sometimes, unlike this video, the fascial plane can be very difficult to appreciate because the muscles are just so hyperechogenic, but again, the blood vessels really help. So now we're going to move on to identifying the subscapularis and the teres major. So you can start with your probe in short axis in almost the identical location as the latissimus dorsi. But what you then have to do is you have to move that probe more posterior so that you're identifying the lateral aspect of the scapula. Once you get here, the teres major will be the structure that's most superficial, and then deep to that and anterior to the scapula will be the subscapularis. So we'll get started here with the video. So if I pause things here, I'm basically at the same level as I was before with the overlying latissimus dorsi, and deep to it the serratus anterior and the ribs. Now I have increased the depth so we can see the subscapularis. Now I'm moving that probe more posterior. As I do so, the latissimus dorsi disappears, and then I'm left with the most superficial muscle, which will be the teres major. Deep to that will be the serratus anterior, the SA that I've identified here, as well as the SS or the subscapularis. Now, as I said, the subscapularis is sort of just anterior to the scapula. So what I'm going to do here is I'm just moving the probe now just a little bit more posterior, and there's the scapula. So now you can see that relationship, that anterior to the scapula and most superficial is the teres major, and then anterior to the scapula, sort of along its borders, will be the subscapularis. And here I am internally and externally rotating, and hopefully you can see movement of that red box, which identifies sort of the muscle contours of the teres major, and then the contours that we see here of the subscapularis. So what I'm going to do here in the next clip is I'm just going to again do movement and just look at those two boxes where those two muscles are. So you see both the teres major and the subscapularis moving. So a great location in that you could actually target both muscles at once with a single needle entry point. Now, similar to Latissimus dorsi, there's no recommended dose per the product monographs for these two muscles. So I'm the neuromuscular mechanic, and I hope you found today's video handy. Take care.